Okay. Moving on to the next disease, which is retinoblastoma. Retinoblastoma is a malignant neoplasm of the immature retinal cells. It is the most common primary intraocular malignancy of childhood. If we talk about most common primary intraorbital malignancy of childhood, then it is rhabdomyosarcoma. Rhabdomyosarcoma. Okay. The median age of presentation of retinoblastoma is approximately 18 months. Patients start presenting from 12 months onwards. In case of retinoblastoma, all patients usually present by 3 years. After the age of 5 years, after more than 5 years, you do not make a diagnosis of retinoblastoma. Every patient will definitely present before the age of 5 years. It's a life-threatening disease because the disease has a tendency to metastasize into the body. So it is very, very important to treat the patient. So most of the cases will present by 3 years. Peak of presentation is at 18 months. Bilateral retinoblastoma will tend to present earlier. Unilateral cases will tend to present later. Okay. What does the patient present with? Patient presents with leukocoria. What is leuko? Leuko is white. What is coria? Coria is pupil. So white pupillary reflex, also called as Amaurotic cat's eye reflex. Amaurotic cat's eye reflex. This is with which the patient will present. That is the most common mode of presentation. MCQ has come. What is the second most common mode of presentation? Second most common is squint strabismus. So whenever a young patient presents with squint, we have to analyze the fundus also. Apart from the squint assessment, we have to look into the fundus also to check for any retinoblastoma. Glaucoma, rubeosis iridis is the most common presentation in advanced cases, and proptosis of eye. These are the various modes of presentation. If we talk about the pattern of growth and route of spread, the pattern of growth can be endophytic, that is inside into the vitreous cavity, Exophytic is outside, that is towards the outer coat. Mixed is the most common mode of presentation, where the tumor is expanding in the both in interior part and the outer part, that is the mixed type. Diffuse infiltrating is the least common type. Okay. In this, what is happening? It is growing along the coat of the eye only. Okay. So this is the diffuse infiltrating type. This has the worst prognosis because obviously the patient will present very, very late. Whereas a tumor which is growing into the vitreous cavity will present faster because patient will present with a leukocoria white reflex. Okay. Since the child is a very young child, normally the child will not say ki I am not able to see. So that is why it is important that the mother or the father or the parents or grandparents, they pick up the odd reflex that is there. Otherwise, because the child is very, very young, the child will not automatically speak up that the child is not able to see with one eye. Okay. What is the route of the spread? Most common route of spread is direct or spread into the optic nerve. It can spread via the subarachnoid space also through the CSF. It can spread anteriorly. It can spread by blood tissues also. The most common method of spread is the direct spread via the optic nerve to the CNS. Okay. Now, when we do a histopathological section on pathology, in a well differentiated type of retinoblastoma, we will see Flexner Wintersteiner rosettes, Wright rosettes, and fleurettes. Wintersteiner rosettes are with a central lumen. Wright rosettes are with a central neuromuscular core. Fleurettes are pear-shaped cells which are there. These are seen in a well-differentiated type. A tumor which is trying to differentiate will have these features which are there. In a tumor which is undifferentiated, you will just see clumps of cells. These are signs that the tumor was trying to differentiate. So if these are not seen, then the prognosis is even poorer. The goal of the treatment is going to be to save the life first of all, then preserve the vision and salvage the eye if possible, and minimize any complications or side effects of the therapy. What are the treatment options that are there? Enucleation and exenteration. Enucleation is removal of the eyeball in totality. Evisceration, evisceration, where you are removing the visceral contents of the eye, you are leaving the sclera behind. Evisceration is contraindicated because when you are removing the inner contents and you are leaving the sclera behind, there is always a possibility that there can be spill of the cells, or there is always a possibility that you can leave some tumor cells behind. So whenever you have to do a surgery, you have to use the sclera as a coat and you have to remove the eyeball in totality. That is enucleation. Exenteration is an extensive surgery where you are emptying the entire orbital contents. You are removing the eyeball, you are removing the extraocular muscles, you are removing the orbital fat, like lacrimal gland, everything you are removing along with lids and everything. That is an exenteration, where you are just leaving the bony socket. That is called as an exenteration surgery. Enucleation, removing the eyeball contents. External beam radiotherapy is one possibility. Local therapies and chemoreduction and chemotherapy. In chemotherapy, the drugs that are used are VEC regime, that is vincristine, etoposide, and carboplatin. Carboplatin. These are the drugs which are used in VEC regime. This is used for chemotherapy. Local therapies can include all form of therapy because we have to, at all costs, we have to kill the tumor. So we can use laser, we can use cryo, we can use heat, we can use radiation. Anything and everything in combination can be tried to kill all the tumor cells because so that there is no recurrence or relapse of the tumor, because it's a life-threatening tumor. If we talk about prognosis factor, optic nerve invasion is the most important poor prognosis factor. So whenever we enucleate the eye, we make sure that we take a large optic nerve stump. At least 10 millimeter or beyond is required, and the optic nerve stump is exposed to histopathology to see whether there is optic nerve involvement or not. A poorly differentiated tumor, I have already told you, has a poorer prognosis sign. Bilateral tumors always will behave poorly, and trilateral retinoblastoma, where there is a bilateral retinoblastoma plus a pinealoblastoma, has almost 100% fatality that is there. This is the what is retinoblastoma. It's a very serious life-threatening disease. It is very difficult to convince the parents to get an eyeball removed. Sometimes parents are lost to follow up, and then they later on present with a proptosis and a poorly formed eye, and that is why counseling of the parents is very, very important. Okay, move on next to differential diagnosis of leukocoria. Leuko, as I was telling you, was white, and coria is pupil. The different diagnoses are PHPV. Co stands for congenital cataract, coloboma, Coats disease. R is retinoblastoma and ROP. I is uveitis and infection toxocara, and A is astrocytoma. So by the mnemonic chorea, you can remember these various differential diagnoses of leukocoria.